contains a lot of lymphocytes, usually 15% of total nucleated count. And most of the T cells, as you can see from the top, and the characteristic feature within the bone marrow is that they are by and large located around capillaries. So you can see the right picture. You've got this linear capillary, and it's surrounded by a layer of plasma cells on both sides. Very nicely seen on the game sustain on the left-hand side. So you see perinuclear box. This is where plasma cells are located in the normal human bone marrow. If you wanted to identify them selectively, you could use various stains. I would use MUM1 as a genetic stain for plasma cells. And of course, we would use light chain staining to identify the different types of plasma cells. So kappa and lambda, and that's a picture of kappa lambda-ish using double color-ish. So the brown color plasma cells are your kappa stained plasma cells, they're predominant, and the red colored ones are lambda stained plasma cells. So the kappa lambda ratio is usually 3:1 in the bone marrow. The bone marrow also contains a lot of lymphocytes, usually 15% of total nucleated count. And most of the T cells, as you can see from the top two pictures, you've got about 4 T cells for every B cell. And the CD4 CD8 ratio in the bone marrow is in favor of CD8 positive cells. So you've got far more CD8 positive lymphocytes in the bone marrow than helper T cells. Bone marrow also contains NK cells, which you can identify using 56 or CD57 staining. They form a very, very small proportion. And I'm often asked this question about how can we differentiate between a normal plasma cell, which is 56 positive, and a normal NK cell. And the answer is that the NK cell, by and large, has a very, very corrugated outline to its cytoplasm, while the plasma cell cytoplasm is very, very smooth and pushing. So it's a very, very smooth outline. That's a good way of trying to differentiate between the two of them. In addition to singly scattered lymphocytes in the bone marrow, you may also get lymphoid follicle aggregates within the bone marrow as part of a normal bone marrow. And there are 3 main types of these lymphoid aggregates. Those with germinal centers, which are extremely rare, those without germinal centers, which are very, very common, and micronodules. Let's try and see what these look like. So the top picture is an H&E stain showing you a very, very nice lymphoid aggregate, and it doesn't have a germinal center within it. So it's the one without germinal centers. And when you do immunohistochemistry, you realize that it's made up of predominantly CD3 positive T lymphocytes with few CD20 positive T cells. And it's very normal to see such aggregates in bone marrows from elderly women or patients with autoimmune disease. Okay, you'll sometimes get lymphoid germinals, as you can see on the H&E on the left-hand side. And the presence of the germinal center has been confirmed by immunohistochemistry for BCL6, which is a germinal center marker, and very nicely seen, same area. So sometimes this happens, especially when you have florid uncontrolled autoimmune disease. You often see these kind of lymphoid aggregates within the bone marrow. And the third type, which I call micronodules, are usually small collections of CD8 positive T lymphocytes. And these are invariably seen after viral infection. So very, very commonly seen when the marrow is recovering from an infective insult. The other type of cell that you can identify in the marrow is the mast cell. Okay, and let's concentrate on the Giemsa image at the bottom left. Most mast cells are located around the bone on the endosteal surface, scattered within the interstitium, or around the adventitious blood vessels. And the Giemsa helps us in identifying these because mast cells are unique because they have metachromatic purple granules. Okay, so you can see that mast cell very, very nicely in the top left corner of that picture. It's got a small nucleus, and it's got, at least this one's got a lot of cytoplasm with very, very nice coarse purple granules. If you wanted to identify them specifically, you could do a mast cell tryptase stain, and you can see that there are very few of them present in the bone marrow. You could also identify them on CD117, where the cytoplasm stains an intense brown, helping to differentiate them from proerythroblasts, which is that cell over there, which has just got a membrane staining, or other types of myeloid blasts. One of the most important cells in the bone marrow is the stem cell. And when I say stem cell, I'm talking of an immature precursor, or what you understand as blasts. And there are various kinds of blasts in the bone marrow, and we use a whole host of stains to try and identify them. The most popular stain is CD34, and usually when you stain using CD34, you get one CD34 positive cell for every 4 or 5 high power fields. That's the normal distribution of stem cells for blasts within the marrow. You can also use CD117, but remember, CD117 is not specific, like you're seeing in the picture at the bottom. It seems to be staining a lot of cells. So it's staining these large cells, these are blasts. It's staining medium-sized oval cells, which are your actual myeloid blasts, and it's staining small cells intensely. These are your mast cells. And in addition, they will also stain plasma cells. So CD117 tends to stain multiple lineages. The type of stem cell in the bone marrow. These are your lymphoid precursors, not very, very common in adult bone marrows, but they tend to be quite frequent in pediatric bone marrows or following stem cell transplants. And an easy way of identifying them is to use TDT immunohistochemistry. So this by and large covers the various cell lines that you would see within the bone marrow. There are other things within the bone marrow which you do need to evaluate, and that is the stroma. The most common stromal element is fat. That's very easily identified. And a couple of things to remember about fat within the bone marrow. One, the amount of fat increases with age, i.e., hemopoiesis reduces with age, which is how we use our cellularity calculating formula. And two, there is usually a lot of fat in the first 2 or 3 intertrabecular spaces, just below the cortex in the iliac crest. So remember never to try and evaluate cellularity in those areas. The other component of stroma that you do not see on H&E stains is the matrix. The matrix is composed of a lot of proteoglycan, which can be seen in things like gelatinous degeneration, so you see it at that point in time. Or there are 2 particular matrix fibers which we like to evaluate. One is the reticulin fiber, and the other is the collagen fiber. Okay? Reticulin is identified using a silver stain. The international standard currently is the Gomori's technique. And the large picture on the right-hand side of this slide is a silver stain preparation, and you can see these fibers. So the silver stain stains them, and these are in between. Let me move on to the fibers. Hold on. Sorry, give me a sec. Yeah. So what are reticulin fibers and what is its function? What do you liquid? Dr. Harini, could I ask you this question? Is the liquid or is it a solid organ?
It's a liquid organ, sir.
It's liquid, very good, excellent. Because you can aspirate it, right? You put a needle in and you pull it out, and it comes out as a liquid element. Can I ask you another question? If it's liquid, why does the marrow in the body not sink to the bottom of every bone every time you stand up?
Sir, it is a gel-like thing being enmeshed within the bone marrow stroma.
Good. So the function of the stroma is to keep the marrow in place, okay? And these pictures try and explain how it does that. So if you look at the top picture, this slightly light orange brown area is the bone trabeculum. And if you look carefully, you can see all of these fibers which seem to be arising from the endosteel surface of the bone and going in between the hemopoietic cells. Can you see that? Great. And as they get into the marrow, if we look at the bottom middle picture, this one, they go and wrap themselves around the arteries which course through the bone marrow, providing support. And then if you look at this picture, they start forming the walls of sinusoid. Can you see that sinusoid over there? It's forming a wall over there. And then they go to the other side of the intertrabecular space and go and tether themselves to the bone trabeculum there. So effectively, reticulin fibers form something like a hammock. And the fat cells and the hemopoietic cells are trapped in between this mesh-like structure. And that is why bone marrow remains where it is. So normally in bone marrow, a reticulin fiber, you will never see a complete reticulin fiber. It always truncates, it breaks off, so you can see only part of it. And that is what normal reticulin is. When you start seeing more of the fibers, that's when it starts getting pathological, and there is a grading system for that. We're not going to go into that today. The second component that we would like to evaluate is collagen. And collagen is only found around the blood vessel. So the presence of any collagen within the marrow is pathological. Okay? And we would use various stains to identify collagen, including Mason's trichrome and the MSP stain. The other elements within a marrow biopsy are the collagenous connective tissue, which is the periosteum. You can see a lot of cartilage in bone marrow biopsies from children and in elderly adults because the iliac crest starts developing cartilage again at that point in time. Below the periosteum, there's usually a layer of cortical bone, which is your dense bone, very nicely seen in this picture on the right-hand side. And then this cortical bone breaks up into thinner trabecular bone. There are a couple of bone-type cells which you can see in marrow biopsies. These are osteoclasts, nicely seen in the left-hand picture, and osteoclasts, which are very, very pretty to look at. And they're often found in small depressions, which are known as Hauschup's lacunae. In addition, the marrow also contains various kinds of ducts, which include arterioles, small arterioles, which then form capillaries, which then open into sinusoids and veins, which drain out of the bone marrow. Okay, let's move to case 4. Dr. Richard, could I ask you what stain this is?
Dimsa stain.
Excellent. And we've already covered this, but what cell do you think is highlighted by this thin arrow?
So it's a large cell with abundant cytoplasm, and cytoplasm have coarse purplish granules and a round to oval nuclei. So this is probably a mast cell.
Excellent. So it's a master. But just remember, these cells are not large. It looks large over here. They're not really large cells. Perhaps if you could move to Dr. Brinda, what cells identified with a short, thick white arrow?
Sir, the cell has a abundant cytoplasm with pink to reddish corpus granules and bilobated nucleus. So the cell is probably the eosinophil.
Sorry, that's an eosinophil.
Yeah.
Excellent. Very good. And what do you think are the cells identified by the red arrows?
Sir, this cells has a bluish, light blue to pink cytoplasm with dark bluish nucleus. The cells are the erythroblasts. Sir.
Very good. Very well. You can see what Ginza helps you to identify different cell lineages very, very effectively. Is Dr. Xenia back?
Yes, sir.
Xenia, could I ask you, if we were wanting to do immunohistochemistry, what specific marker would you use to identify this mast cell?
Sir, CD117 and sir, tryptase will do.
Excellent. And if you were to identify the erythroid cells, what markers might you use?
Sir, glycogen A, hemoglobin A, so that we'll use.
Very fantastic. Excellent. So I think this indicates that you all have taken up what has been said up till now. That's really good. Okay, another 10 minutes or so. We just quickly cover a few other aspects. What are the advantages of the bone marrow trephine over the bone marrow aspirate? Okay, you have to remember this is not a fight between the histopathologist and the hematologist. Okay, both of them are complementary. They provide information, different kinds of information, and you need all of this information to come to any kind of sensible diagnosis. The things that you can get out of the aspirate is cytologic detail because you're looking at stuff at 100x magnification. So it's brilliant to identify cytoplasmic granules, cytoplasmic structures. It's very easy to do counts on the aspirate. It gives you a very, very accurate iron status because there is no processing involved. So whatever iron you're seeing is effectively a very accurate representation of what's there in the body. And it's brilliant for identifying ring sideroblasts. Okay. On the other hand, the trephine gives you architecture. Okay, something that you can't see on the aspirate because we are dispersing cells in the aspirate. You can identify fibrosis and assess it. You can identify stuff like amyloid, stromal changes like gelatinous changes. You can identify changes occurring to bone, like say renal osteodystrophy, Paget's disease, osteoporosis, that sort of thing. The brilliant advantage of the bone marrow biopsy is that you can do immunohistochemistry or ISH, which in relation with architecture gives you a lot of very, very important information. It's really good for accurate characterization of metastatic and infiltrative processes, say like granulomatous pathology or metastatic carcinoma, and also identifying where these come from. If you're getting a bone marrow biopsy as part of a workup of a cancer of unknown primary, it's really good for identifying on the edge. And it's currently probably the best mechanism for evaluating MRD and myeloma, irrespective of what the flow doctors say. A bit about FISH on bone marrow biopsies. It's really type of decalcification is really important for whether your FISH is successful or not. And if you do EDTA, we've had fantastic success, 100% success rate. If you're using acids for decalcification, FISH tends not to work so well. And you'll come and ask me, why would I do FISH on a bone marrow biopsy? Because I've got an aspirate handy. It's so easy to do it on that. Well, you may not have an aspirate, or the aspirate's not been sent for cytogenetics. The aspirate may not actually be representative, i.e. it may not contain malignant cells, or the malignant infiltrate is very, very focal and you can't see it. And the other thing that you've got to remember is highly proliferative lesions. If the aspirate is not collected properly, all of the cells are going to die in your tube before the cytogenetics people can make any sense out of it. So then often you're left with the biopsy as the only bit of tissue that you've got for diagnostic purposes. PCR, again, fixation and decalcification dependent. You can see that with EDTA, DNA quality is good. With AZF, it's really, really poor. And the usual tests that you might be asked or you might want to do on bone marrow biopsies are IgH and T-cell gene receptor studies, or sometimes EGFR or NGS for metastatic lung cancer, or rarely BRAF for Langerhans cell histiocytosis. This is a slide which tells you what impact fixation and decalcification has on ancillary techniques. So neutral buffer formalin is excellent for everything as long as it's less than 24 hours. AZF is good for immunohistochemistry. We don't have data for FISH, but DNA quality tends to be really, really bad with AZF processed bone marrow, so you can't do molecular studies on them. And if you look at decalcifying agents, the bottom two rows, EDTA seems to tick all boxes, so you can do immunohistochemistry, FISH, and molecular. While if you use any decalcifying agent which contains an acid, FISH and molecular tend not to work. And this is what we would routinely do in practice. We would fix a neutral buffer formalin anywhere between 12 and 24 hours. We would decalcify using EDTA in a heated oscillator or we would routinely process overnight. We would embed in paraffin. We'd cut HNEs at about 2 microns. We'd do 3 levels. We'd do a Pearl stain. By and large, we've now stopped doing GIMSA because we've got immunohistochemistry. We would routinely get a reticulin done at source, and we would get the laboratory to cut 15 unstained sections and keep these ready for whatever immunohistochemistry we might want to request. So this is the standard protocol for evaluating bone marrow biopsies. Thank you very much. I hope this was useful, and I'm going to stop sharing.
So thank you very much, Mufi. I think you're getting a lot of claps and all sorts of other, praise in the chat box.
Oh, nice.
Yes, it is. I think it's you took everybody through the normal bone marrow, which I think very few people do as well as you have done, because we tend to focus on abnormalities, and I think without looking at normal, it's very hazardous to look at abnormal, which you have very clearly said at the beginning of your talk. Now, there are a few questions in the chat box, Mufi, so if either Lopa or Shubha would like to.
Yes, ma'am. Yes, ma'am. I could see 3 questions. Number 1, why there is a short of donation for hematopoietic cells, like peripherally situated myeloid, then erythroid, and inner megakaryocytes?
I mean, why it's the way it is?
I think they mean to say that.
Yeah, I guess why is the marrow zonated in the way that you talked about, which is what it is in normal. I think you partly said that, Mufi, when you talked about the megakaryocytes being where they are. So maybe you could explain.
So you've got to remember that unlike most of the organ systems where you largely see the mature end cells, say for the liver, you never see the immature liver precursors, you only see the differentiated hepatocytes. The marrow is very, very different in that every lineage, you have multiple stages of differentiation being seen at the same time. Now, all of these stages require space, okay? And you have to remember that the function of the marrow is to send differentiated cells into blood. The important thing to remember is immature cells cannot cross into blood because the basement membrane and the endothelial cells simply will not let them through because they do not possess the receptors which unzip the endothelial cells. It's the receptors and are able to squeeze through the endothelial cells. So the immature cells are located in a place where they're able to form their intermediate stages and then allow the differentiated cells to be in the right location where the sinusoids are, which are in the center of the intertrabecular space. Does that make sense? So that's why you get most of your immature precursors at the periphery, and you get most of your differentiated forms towards the center.
Yeah, I think it makes sense, Mufi, and I hope
that's about as good an explanation as I can give you.
That's Jayashree who has asked the question, and I think Jayashree, I think that seems to be a very good explanation because your sinusoids are running through the center of the intertrabecular space. I mean, that's the way it is, and you obviously need, as Mufi, as Dr. Mufaddal said, you do require only the differentiated cells to come anywhere near the sinusoids. Now, if you ask, why do you get, the myeloid series close to the trabeculae and then the erythroids and the megakaryocytes towards the surface? I think that's very difficult to explain as to why you get that 3 levels of differentiation. But you might as well ask, why is the kidney arranged the way that it is and the liver arranged the way that it is? There must be some kind of functional reason why that is so. Because I think when you have a bone marrow transplant, you also see that the cells go and home to the area where they are normally situated. So there is some kind of homing mechanism, but exactly what it is, I don't think I know. But I think it's worth finding out. That's an interesting question that you have asked. Okay,
Yes, ma'am.
Lopa?
Yes, ma'am. I think she's telling thank you. This thing.
Okay.
Second question: can E-cadherin be used for identifying erythroid precursors, or will glycophorin stain early erythroid?
Yes, E-cadherin can be used. It is not specific for erythroid. It stains a lot of other things apart from erythroid. So just remember that. Glycophorin also stains erythroid, but as I've said, it is not specific to stage of differentiation. It stains everything, right from your most and often the which is within the biopsy makes it very, very difficult to interpret glycophorin. Now, the good thing that you'll be really happy to hear is that you tend to use glycophorin more when you're trying to assess for dysplastic changes in the bone marrow, and in that particular situation, the erythroid colonies come out beautifully, and you can see both architectural as well as cytological abnormalities. So it does work really well.
And the third question is why T lymphocytes are more in number as compared to B lymphocytes in the bone marrow, when we very well know that B lymphocytes are bone marrow derived cells.
Hello.
Did you hear the question, Mufi?
Sorry, no. Could you just repeat the question? I think I saw it on the chat. One second.
Yeah. Okay.
Now, that's a really, really good question. I don't think I have a very, very ready answer for that. Not entirely sure, but I think you've got to remember that we are largely dealing with adult bone marrow biopsies in our diagnostic practice. and most of these inferences are based on proportions in adults. But I have to skip that, man. Do you know why this might be so?
No, but I think that, this is a reflection of what's there in your peripheral blood. Because in your peripheral blood, if you look at the lymphocytes, it's the T lymphocytes that circulate. There is a circulation of T lymphocytes, and that's why the proportion of T lymphocytes in your peripheral blood is always more than B lymphocytes. B lymphocytes tend to home and stay wherever they are, and then there's not much circulation of B lymphocytes. And I think that this is probably a reflection of that. But I agree with you that I don't know exactly. I think when B lymphocytes are formed in the bone marrow, we talk about them being formed in the bone marrow. They get into blood and home to their normal sites, whereas the T lymphocytes are constantly recirculating, and I think that's just part of the recirculation of T lymphocytes. That's what I think is the answer. I must confess that I never thought about it. I never asked myself that question before.
Next question.
That has answered Babita's question.
Next is Ankita Raj. If we are getting paratrabecular lymphoid aggregates, should we say bone marrow is involved and advise ISC or flow?
But yes, if you're getting exclusively paratrabecular lymphoid aggregates, it would be pertinent to investigate further to determine whether the bone marrow is involved by follicular lymphoma. Yes, you should do more investigations.
Next question from Vanisha John. Any specific percentage for EDTA for decalcification? Percentage of EDTA?
It's 10%. It's a 10% solution.
Ala Umran. After bone marrow biopsy fixation in neutral buffered formalin.
And please remember, you do have to do pH testing on EDTA before you use it, because, sorry.
After bone marrow biopsy fixation in a neutral buffered formalin, AZF alone is enough for decalcification.
Yes, AZF is fantastic for decalcification, but just remember, if you're going to be using AZF, you do not need to put it in neutral buffered formalin. It's a combined fixative and decalcifying agent, i.e. it fixes and decalcifies simultaneously. And that's why it is able to do both within 18 hours. So you take your biopsy and put it directly into the AZF solution. And at the end of 18 hours or 24 hours, you will get a fixed and decalcified bone marrow biopsy.
The next question is, if bone marrow is involved by T-cell lymphoma based on CD2 and CD3, what ISC should we use after that for subclassification?
That's a very, very good question. It depends on what kind of T-cell lymphoma you're thinking of, right? And we've got a huge host of cell markers available. So if you're thinking of a T-cell lymphoma, the first thing that we would do is try and see what kind of expression of pan-T-cell markers you would have.
Mufi, we lost you for a minute.
Specific like thinking of large T-cell lymphomas, CD56, if you're external.
Yeah, I think we lost you for a bit, Mufi, but I think maybe the short answer is that if you've got a lot of T cells I think you would do what you would normally do in a lymph node to try and identify what these T cells were, particularly if they have dropped or lost any of the pan T cell markers, and then proceed accordingly. If it's a kid, of course, you would probably need to do TDT, not that you wouldn't do it in an adult. You need to just work it out as if this were, depending upon the history, depending upon the age, depending upon the peripheral blood profile, you would have to work it out. Okay, I don't know why Ala Umran asked about CD2 and CD3. Mufi, do you do a 2 straight away, or you just do a 20 and a 3?
It's just a 20 and a 3.
20 and a 3, yes. So I'm not sure why the question said that, talked about T cell lymphoma. I guess it is a T cell proliferation based on CD3, and then what would you do after that? Yeah, I know, CD20. Are you talking about CD2 or CD20? I think there is a something missed over. Okay.
Yes.
All right. Any other questions in the chat box that I might have missed?
I don't think
right.
There is no more question.
Right. I think all the students have probably benefited a lot, particularly those who were interacting with you, Mufi, because nobody could have done a more interesting and a very systematic way of examining a bone marrow biopsy.